Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast
With your hosts,
Zee
and John. So, hi, Zara. How are you?
Hi, John. How are you? I'm doing well. Thank you for asking. It's another glorious morning here in Vancouver, British Columbia.
It's a very hot day down here in New Jersey. Delighted to have a really great guest speaker I've known for multiple years on this show today, Dr. Michael Staehler, who is professor and head of urology at the Munich Institute. So we really want to thank Michael for coming to our show today. And Michael, if you could just tell the audience a little bit about all the research that you're doing over at the university there at Munich, and also your experiences within renal cell carcinoma.
So renal cell carcinoma is something that really attracted me when I was really little. It's a fascinating story because I got to it first time with my grandfather, who was a urologic surgeon as well.
Mm.
And he had a story in his diary where he talked about a patient with kidney cancer that he did a metastatectomy in 1930, and the patient still was alive in 1945. So this metastatectomy kind of cured him, and it caught my attention. And my dad, who also was a urologist, was in kidney cancer as well, and so that's what dragged me into it. Here in Germany, we have the specialty that we also do systemic therapy in those patients. So we not only do surgery in kidney cancer, but we also treat them systemically. And I got involved in the first TKI trials and stayed on with mostly all of the pivotal trials of the new drugs and drug combinations. Basically, with the main focus on PROs. So always the patient always was in the center of my interest in how can we reduce harm to the patient and improve outcomes. That was kind of what always was driving me.
Sorry, Michael, you made a comment around an acronym, and we're so used to acronyms, but can you just explain what PRO is, just to our listeners out there?
So that's a patient-reported outcome.
Okay, brilliant. Thank you.
And Michael, you've been involved in the early research associated with these trials. So maybe it would be really good from your perspective to talk about trials and then how do pharmaceutical companies actually monitor for adverse events and treatment outcomes from a stage 1, stage 2, and stage 3 perspective, and then take the patient through how we collect those adverse events and treatment outcomes.
So basically what we're doing is we're trying to figure out if any drug that we're testing has efficacy and has some harm to the patient. The harm is called a side effect. The efficacy is that what we want to use it for to improve any condition. Our goal there is first to figure out, is there a tolerability of a drug? That's a phase 1 trial. Which is the right dosage for the patient? Do we see any adverse signals that would prevent us from using that drug any further? Further on in phase 2 trial, we're going to look more into efficacy. Is this drug actually at the dose that we think is right active? And then later on, we're going to bring it into the clinical setting in a phase 3 trial where we really want to know how active is it? Is it comparable to other drugs in the field? And what are the side effects exactly in a larger patient population? These are basically the 3 stages of investigating any new treatment options that we bring to patients.
And maybe you could explain the patient population that we select for those big, large randomized phase 3 trials, which are against the standard of care, and what the difference of those populations are versus the patient that you see in your practice. Maybe talk a little bit about the inclusion and exclusion criteria.
So if we're investigating a new drug, we want to make sure that the signal that we're seeing comes from the drug and not from underlying conditions of the patients. So what you do is you super select the patient population in which you test the drug. That said, you're going to exclude some patients with conditions that could interfere with your outcome of the trial. Like, for example, if you want to see a drug that influences the growth of vessels, you're not going to accept patients who have a severe heart condition that would prevent them from actually being able to go through that therapy because it might interfere with their cardiovascular system, and then can put the results of the trial at harm. And there are a lot of conditions in patients, comorbidities, other diseases that we want to exclude from these investigations to get a clearer signal of what's really coming from the drug. It also tells us more about the efficacy and the duration of efficacy, because comorbidities actually can influence not only side effects, but also effects of that. And we would then not be able to really show what the drug is able to do and eventually get it approved.
But then isn't the challenge with that that when you are so selective for the clinical trial inclusion and exclusion criteria, the patients that come to you, come to clinicians in their office settings, do you then exclude those patients because that means that you are holding back a treatment modality based on an exclusion criteria in a trial?
So first of all, I'm not holding back anything. I'm not offering something. There's a difference. It's a fine line, but it's an important line. Holding back means I have something for the patient that I know is going to help them.
Mm, okay.
That would be holding it back if I don't offer it. A clinical trial, I have something that might be effective, but I don't know. And I don't want to put the patient at harm's risk in this situation where they already struggle with their health from other underlying diseases. I'm not going to offer it to that patient to be included in the trial. I can't offer it because he would be excluded right
Right.
away. So the better way is not to offer it in the first place. But I'm not keeping them from anything. They might not have the chance to get a drug of the future, but right now they don't get it.
Okay. And in those patients in renal cell carcinoma, you've got multiple combinations of therapy and multiple approvals now with different combinations, TKI, immunotherapy plus immunotherapy. How do you make those decisions based on the patient's status or performance status versus the combination that you select? Do you base the combination on the previous experience or the clinical trial outcome regarding efficacy and adverse events, and then sort of select the patient for the trial based on their performance or comorbidities?
That's a really good question. How do we select patients for therapies? If you look at the results of trials and you would write them down and just compare them to each other and see what were the inclusion exclusion criteria, you're going to have kind of a computerized system that might inform you about which could be a therapy for a patient.
Mm.
But that's not medicine. Medicine is experience. Medicine is understanding not only the data from clinical trials, but also the patient's situation, his specific circumstances, his comorbidities, his needs, what he wants in life, and what he expects you for the therapy, and what he is able to invest into that treatment that you're going to go through together in the next couple of years, hopefully. So medicine is bringing all those things together and then offering the patient maybe one, maybe multiple treatment options and figure out what we're going to use in a specific situation. And don't get me wrong, it's always going to be a complicated decision and you can't turn it back. You can't come to that point in time where you decide on a first line therapy again and be like, hey, that one didn't work. Let's do it differently, because then you're already in second line. So we're always at risk here of doing it wrong. So nobody's going to have fixed criteria, which is the best situation for a specific therapy. It's always a little bit cloudy, but based on our experience and the data, we can come up with at least one recommendation, if not multiple.
And then where does the discussion around the side effects for that specific modality or modalities come in? If you could further just explain on that or elaborate on that.
This is something where I'm really into because everybody's like, patients don't want side effects.
Mm-hmm.
We don't want them to suffer through this. We want to improve their quality of life, or we want to increase it or not interfere with it too badly.
Right.
Sounds wonderful. Why do we think that way? It is if we offer a patient a certain treatment, the first question they ask, what are my side effects going to be?
Mm-hmm.
Do they want to know about the side effects? Do they want to avoid it? That's how we interpret it. But they don't. They just want to know what is the price tag for that treatment. It's like you're going to the car dealer and you're like, I want this car. It's so beautiful. And that's what I've dreamt of. The next question is not, is it the right car for me? The next question is, what's the price? And this is what the patient is asking here. What am I going to have to pay for my treatment?
Right.
And we turn it around and we think this is what all that matters to them. But make a simple example. You have a headache and your painkiller is going to give you some stomach pain the next day. If you take it, you're still going to take the painkiller because you know that being free of the headache is worth more than never having to experience the stomach ache.
Correct.
And that's the same situation with patients. So actually, they're not worried about side effects. And we did some research. Patients are willing to accept side effects. They just want to know which they're going to be and what they expect from their therapy and whether they need to be concerned if they experience certain changes or not.
You are in this tipping point where the efficacy that you're offering is going to, as you said, outweigh the potential of an adverse event. How do you make that tipping point level where the efficacy versus the adverse event is in balance with the patient's decision to accept that price?
First of all, there's no way to predict side effects for any given patient. It's not like you offer them a certain therapy and you know they're going to have a high blood pressure or diarrhea or some skin rash. You don't. There might be a likelihood that that's going to happen. In my belief, you should not offer a therapy based on side effects. You should choose the most active therapy for the patient and then manage the side effects and negotiate how you're going to get the patient through that phase where they have the side effects. Because usually they cannot experience efficacy. Efficacy is that your cancer is not growing. Efficacy is that you're still alive.
Mm-hmm.
But
Yeah.
you don't know if you're not alive anymore. You only know I am alive and you're going to experience side effects during that time. So the efficacy you cannot really see. You might get a glimpse of it when you get your scan results back, when somebody tells you, hey, that worked, or it's stable, or you're in a good situation where we don't have to think about anything. Then it gets a little bit more informed about efficacy, but you're never going to be able to compare it to what would have happened if you would have done something else, no therapy or a different therapy. I would always offer the most effective therapy for a patient and then work through the side effects, manage them honestly, and motivate patients to talk about it.
Great point you just made. Motivate patients to talk about it. Because from your experience, and again, as a nurse, I've seen it as well, typically patients don't want to feel that they want to burden their clinician with, hey, doc, I have such and such side effects. So within your experience, do you find that patients actually come to you or your nurse proactively to request for management of their side effects? Or is there something that you can share for those listeners out there that don't take that proactive approach?
So usually patients don't tell us about their side effects proactively. We do estimate from patient to patient surveys that 85% of the side effects never get reported. And there are some trials, one of them is called, for example, FAMOUS, where we do actually have data on the discrepancy about the reporting of the patient towards their doctor and what's really going on. And I think this is like not only a gray, but a dark zone of information there. You got to ask proactively patients, and you have to offer them something else than just the two things that they expect us to do, which is either reduce the dose or withdraw the drug, because these are the two things that they don't want.
Right.
Reducing the dose means reducing efficacy in your understanding. Withdrawing the drug means I'm going to die.
Yeah.
I'm not going to have any therapy that keeps me from dying. So your motivation to get your doctor to do that, to take away the efficacy of the therapy that you so desperately want, is not really high.
So what do you do in that case? Like, how does that conversation happen?
It is not that case. It is every case. It is every patient where you have to be like, hey, now we talked about the efficacy. You can run through the scans or whatever. And then you can say, but now just like, let's talk about how do you feel? How does that therapy influence your daily life? What has changed for you because you're on that therapy? How can I help you with that? And we're not talking reducing a dose or whatever.
Right.
That is when we're in that situation. On the other hand, what I like to do is that at the beginning of therapy, I like to run the patients through 7 to 8 most likely side effects that they might experience. I don't hand out pamphlets.
Okay.
I ask them to throw out the prescription leaflet and not read it. But I want them to use a piece of paper and a pen and write down recommendations how to proactively deal with these most common side effects. Because the moment they walk out, they forget about it. And what they wrote on a piece of paper, they can go back to it. They understand what they wrote, how they wrote it, and what they want me to do.
I think that's excellent advice. And I think that we need to keep referring to that. So listeners out there, please, man, it's very good advice. You're right. I mean, typically patients would keep that pamphlet, refer to it constantly. So I think what you've just shared is very valuable. So thank you.
I learned that from my cousin. She's a juvenile diabetic, and when she was first hospitalized, they offered her like whatever 60 different pamphlets, and she took them all back home. They're still there. She never looked into them. Everything is in there, but she doesn't know about it. Pamphlets, in my experience, only have very limited reach in patients. The thing really works is that you ask them to write it down themselves. This is what really works for them.
Oral therapy can be also a set and forget. You brought up two of the most important factors. One is the efficacy, and then one is I don't want my dose to be reduced because I might lose the efficacy. So what steps do you take at the hospital to monitor and to encourage patients to talk about it? Is there a proactive approach? Is there an outreach program that you have or you should get patients to be involved in?
What we learned quite quickly with the orals is that patients actually take them. Again, they want the efficacy. They want their cancer to be under control. And if you look at the data that's out there, about 98% is the compliance of those patients. So they do take it. If you have the impression that a patient is not really cooperative with those drugs, you should have a non-punitive, open discussion and listen to them. What are their concerns? and why do they not want to continue on that therapy, which means not taking it? Why do they need a break? And maybe you got to alter the treatment schedule. We do have continuous therapies. We also have discontinuous therapies. So there might be a situation where you actually build in a pause into a continuous therapy because the patient needs that break. And I personally don't believe that a week or two of therapy is going to really destroy the effect of the therapy. It's just going to help the patient to stay on for a longer time, maybe at a lower dose over the longer time, but a higher dose than withdrawing it after a time because they're just done from the side effects and can't stand it anymore.
So it's very important for patients to know that listening to this, drug-free holidays are really good for them, as well as managing their adverse event at the same time while keeping them on therapy.
For example, for Christmas, we offer everyone orals a drug holiday. And you can decide that Christmas actually might be sometime else in the year. Just offer it there as well.
I like that.
It's a bit of a Christmas present. Thanks, Michael.
So, Michael, within your research, within your expertise in treating renal cell carcinoma, can you elaborate if there are any specific side effects that you have found to be challenging or interesting within renal cell carcinoma therapies?
So actually, a lot of them are really challenging. One of the biggest issues for patients, which is the most common one, is diarrhea, because it's not that kind of diarrhea that we're talking about. It's immediate onset, and they really can't make it to the bathroom anymore. And we got to address that proactively. So that is one thing where we talk about with patients initially how we would want them to manage that and how we would want them to address it. Then there are other side effects, like, for example, liver enzyme elevations, ALT, AST going through the roof or whatever, where we got to talk to doctors and explain to them that an AST, ALT of 200 might not be too bad, and you can just continue on that. And maybe don't draw blood that often in patients, and don't do it every week. If the patient's doing fine, you can keep it going. And there is a lot where it's a lot in the eye of the beholder. And we do know that there is a whole lot of side effects that patients don't want to talk about it. I mentioned it earlier, for example, all the TKIs and mTOR inhibitors, they interfere with erectile function in men.
Okay.
And depending on your age, you might actually be impotent after using them.
Right.
Most patients don't talk about it. They might talk to the urologist. That's how we learn about it. And we ask about it. We have questionnaires for that every patient in the waiting room is filling out anyhow. And you kind of got to aggressively talk to them about it. They don't feel comfortable talking to the oncologist by themselves. Even worse is with women. Women have sexual dysfunction and discomfort a lot. They have vaginal dryness. They have discomfort. Everything is tight and hurts, and there is interest anymore. Not only because their libido is going down, but also because their bodily functions are reduced. They really don't want to talk about it actively. It's a tough thing. We learned that from patient groups, and there are some patient advocacy groups where patients can help themselves talking to each other with that about any kind of problem, and that's really helpful. And if we know about it, we can help them if they trust us to be a partner in that situation. And sometimes the oncologist is not the right partner to talk to if it comes to sex. I mean, it's not the relationship that you expect to have with your oncologist.
Right.
But on the other hand, we should be aware about it and we should address it and maybe send them to a specialist. Maybe tell them there's help out there. There are, for example, Casey Cure. They have those patients groups where patients talk about that and help each other about it. And there are other groups like that all around the world who help each other. Or you can direct them to some groups where sexual dysfunction is discussed. But you need to be aware of it, and you should be really open and not make it something that people don't feel comfortable talking about it.
Sorry,
But there is no data out there. We don't officially, we even don't know about it. It's not in any of the tables that we see at conferences, but it is really, really prevalent in almost the majority of the patients who are sexually active.
Okay, I have a number of questions from that. So my first one is, you mentioned a support group. I missed the name of that support group. Could you just say that
Casey
again?
Cure, for example,
Casey Cure?
kccure.org.
Okay. Okay.
That's a great resource. I direct all my patients there. There are some national ones, like Canada has Kidney Cancer Canada, for example, because they're from Vancouver. And in Europe, there are other groups as well. If you Google them, you can find them.
Okay. And I guess the other question I have is, so with regards to, and it's an important topic you're bringing, because you're right, it's difficult for patients, to have that conversation with their oncologist about erectile dysfunction, or if you're a female, any sexual issues that you're having. Now, from your experience, is this due to the cancer? Like, how do you know, are these causes due to the cancer, or is it also due to the medication?
Both is possible. Cancer actually can interfere with that function, with this body function a lot, but mostly it is actually from the therapy. If you have a TKI, all your epidermal systems are kind of influenced by it, and that's why we have a stomatitis, mucositis, and hand-foot syndrome, and it doesn't stop at your genitals. And so we know about it. We just don't describe it in that area. It's kind of a no talk zone. And we are aware that it's happening, and it is actually coming from the therapy.
From this discussion, and if listeners are there, A is they should be trusting to their oncologist, obviously, and be able to talk about it. If not, then consult with KCA or one of those groups. With KCA's national and international, so that is a good group for them to reach out to. But it's something that was a surprise to me, because being involved in research since 2005 in renal cell, I've never actually heard of this in any clinical data form.
It's not. There is no questionnaire. There is not an erectile dysfunction questionnaire that you provide patients with cancer. So it's not known. And again, patients sometimes might not feel comfortable talking about it. And maybe you as an oncologist aren't the right person to address it. But again, direct him to a specialist. We sent him for a psycho-oncological evaluation and consult. We can also send them to some people who are more likely to be the right partner in that. And if you have a great nurse, a female nurse with your patients, and you have female patients, ask them to talk to the nurse. That sometimes is much easier than to talk to the doctor. And we do know that reporting to nurses, reporting to doctors, reporting to peers reveals different side effects and different complaints. Nobody is bringing them all together. Only the patient is suffering through all of that.
Based on, again, what you just mentioned, then would it be a good idea for you as a clinician or your nurse to then bring this up with your patients proactively, given that they don't want to talk about
Yeah,
it, right?
yeah, you should. Anything we learned that in life, kind of. Any time we talk about things without hassle, without holding back or whatever, it becomes normal. And we can have that conversation. If somebody doesn't want to talk about it, if they want to sacrifice that bodily function because other things are more important, like being on therapy, having efficacy, focusing on other things in your life, it's totally fine. Nobody is forced to answer you. But you can say, hey, if there is something else, if you have problems in your relationship, which we know you probably will experience, then you can talk to us about it and we can help.
Okay.
Or we can send you to a specialist. If you say, hey, you need to be referred to a specialist, that might be really good for a patient to know.
Right.
But as physicians, we can be open to it. We can actually look beyond the data that we see on a big conference on the board there,
Right.
and just have a more open and thorough conversation with our patients.
And would you see that side effects, generally speaking, including the sexual dysfunction side effects, do they increase as you go further down the lines of therapy?
Some of them do, some of them don't. It depends a little bit on the patient. It depends a little bit on the drug you're on. So there is a time dependency. Some of them might be just in the initial phase of therapy and then wear off over time, or patients learn how to manage them better and doesn't bother them that much. So just by managing them, they go from a grade 3 to a grade 1 or even less than 1 kind of. And so this is highly individual here. We never look at those time aspects of side effects. Is it all the time? Is it in the beginning? Is it like at the end or whatever? That's usually not reported.
Where do you go to if we were talking to a patient today with basically said to them, you've got your trust with the doctor, you've got the side effect profile, and more proactive about your management of your side effects. How does this all play into their families, also their caregivers? Are these people within the team? Is this a multidisciplinary approach to management of adverse events? Do you all get together and discuss this? Is this something that's coordinated? It would give better results?
So that's a really good question. And I usually tell every patient in the initial discussions that we have before we start therapy, put together your care team. And the care team for a patient is the patient for sure. It is the spouses, it's the family, it's friends, it's might be work colleagues, it's the doctor, the oncologist, it might be the urologist, a GP, the psycho-oncologist, maybe early on palliative care, and so on and so on, and just bring all those people together so that once you need them, you have them around you and you don't have to go and find them. It is sometimes it takes a village, and not only in all other aspects in life, but especially in cancer care. And we as oncologists, we're just one part of it. And we should be open of bringing everybody who has a stake in there to come together for a better situation for the patient.
Yeah, it's been interesting, this conversation, for the simple reason is that we had a lot of doctors on Med Insights Unleashed talking about efficacy of a trial and managing their efficacy and their disease through a multidisciplinary. We've never really discussed a multidisciplinary approach from an adverse event side. And I think this is a revelation for myself, as well as maybe our listeners here, is that cancer patients should not be alone. It's a multidisciplinary team approach to ensure that they've got the confidence to carry through with their treatment, but also that the family is aware of the impact of the treatment that they've got from an adverse event side. So, Michael, you've brought together some unbelievable points today.
Yeah.
Basic education that we should do. And we do a lot. A lot of our colleagues are actually aware of that and do it in their daily clinical practice. That makes a good doctor, that you address things like that. Let me tell you a story about how I mean these things and why they're important. So we had a patient, he was really young, in his 40s, widespread metastatic disease. And he was coming back, and walking from the waiting room to the clinics. I picked him up there and I read his report, his radiology report, while walking, and he had it read it too. He had a near complete response from a really, really nasty widespread disease. And I'm like, oh my God, that is awesome. While we were still walking, and I look at him and go like, this guy is walking a little bit weird. It doesn't look like some normal person walking. He seems to be somehow in pain or discomfort or whatever. We sat together, we went through the report and everything, and the labs and all these objectives. And I'm like, so that's really great. I'm really happy for you. How are you doing? And he's like, I'm fine. And I was like, that's weird. He was walking so funny. And I always make their spouses come with them.
Mhm.
to the consult. And I looked at her and I said, is that about right? And she's like, yeah, maybe. I'm like, what does that maybe mean? We uncovered 28 side effects,
Wow.
some of them grade 4.
Oof.
He didn't want to talk about it, even after having been asked 3 or 4 times. And his spouse didn't really want to talk about it, but she hinted to some things, and we took it from there and could reveal 28 side effects. It wasn't hard to fix, actually. It was pretty easy to make everything more comfortable for him and to overcome, let's say, 27 of the 28, and the last one was then down to a grade 2, which he could stand. But you gotta address it. You gotta bring in all the information you can get, and sometimes the patient is not a reliable source.
Right. I think you said it earlier, and John, it was the question that you asked was it's the bringing together the care team. I actually love that word that you said. It's every patient needs to have their entire care team set up from ahead of time and not to be afraid to ask. It does take a village, and I think it takes a lot of courage. And we need to encourage patients as much as possible that, reach out to your friends and your family members, etc., because it truly does take a village. And it's that patient that you're referring to was lucky that you invited the spouse to help uncover that conversation. Otherwise, you wouldn't have been able to identify some of the side effects that they were going through.
We always do. We always do. I always bring in the spouses. I always bring in family. I want to have this as an open discussion. And, if you have bad news for them, it's good that the spouse is there.
Mhm.
If you have good news for them, it's even better that they're there.
Michael, I think we've had a wonderful conversation, but I'm also cognizant of our time with you in Munich. That I can see your background getting darker, and I'm like, oh my God, it is getting later for you. If you could be so kind, and we've had a wonderful conversation, can you parlay some key points as key takeaways for the listeners and the patients that are out there based on our conversation that we've just had with you?
What is most crucial in the treatment of metastatic kidney cancer is to choose therapies not on side effects, but on efficacy. That,
Mhm.
to me, is really important. Then proactively manage side effects before they actually occur. Talk to the patient, build a care team for the patient with the patient in the center of it, and just be kind and listen.
Wonderful. Thank you, Michael. That was great.
Thank you, Michael.
You're welcome.
And we'd
And
love to have you back.
it's been great chatting.
Yeah, enjoy the day.
Perfect.
Yeah.
Thank you very, very much, mate. Med Insights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. Med Insights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next Med Insights Unleashed podcast.